Honored to be here speaking with you, so I thank you for the invitation, and thank you to Christian for inviting me to come and speak. And when he asked me to come and speak on the topic of pseudoscience, I thought, well, that will be very non-controversial, and I do look forward to a lively discussion around this issue. It does relate to the dodo bird verdict. In Alice in Wonderland, this took place after what was called the caucus race, when everybody ran off in very different directions, and at the end of it all, when nobody had seemed to get anywhere, the dodo bird, who was judging the race, said, "Everybody has won, and therefore all must have prizes." And that has become the verdict for several people when it comes to psychotherapy, and for other mental health treatments as well. What we're going to talk about today is how we distinguish the scientific from the pseudoscientific processes in mental health treatment, both the psychotherapeutic treatments and the somatic treatments. Let's begin with a quiz. Now, you don't have to answer this, but if you think about it, there are a number of different psychological treatments out there, and some of which you might think of as scientific, some of which you might think of as pseudoscientific. And similarly, there are a number of different somatic treatments out there, also which we might think about as being scientific, or we might think about as being pseudoscientific. The question is this: can you look at this list and determine which of these treatments are scientific and which are pseudoscientific? Now, I thought about this question, and I stared at this slide myself for quite some time. And I realized, as I was preparing to come and talk to you today, that there are two different paths that I could take for the next hour. One path, which I think would be the easy path for us all, would be for me to divide the mental health world into two camps and say, these are the scientific treatments, and these are the pseudoscientific treatments. And then I would proceed to spend the next hour giving you a list of things I don't like in the field of mental health. That would be fairly easy because I can come up with a list fairly easily of what I don't like. But I think that that probably would miss the mark. What I'm going to suggest then is a slightly different path, a more complicated path for us to think about. But I wanted to make two hypotheses, lay two premises out for you. One is that treatments are not inherently scientific or pseudoscientific. What I'm suggesting to you then is that there is no such thing as a pseudoscientific treatment, nor is there such a thing as a scientific treatment. The second is that the labels science, pseudoscience, apply specifically to how the proponents of any given technique or treatment deal with the evidence, and in particular, how they deal with the evidence that contradicts their cherished hypotheses. In essence, then, what I'm suggesting is that science and pseudoscience are behaviors. They are not products. Therefore, what we're not going to have, and this may please some and displease others, we're not going to have a dirty list of bad treatments, nor are we going to have a wonderful angel list of great treatments. I'm going to suggest instead that science and pseudoscience are both behaviors of which we are all capable, and sometimes perhaps all culpable. In that essence, then, I am a pseudoscientist, and perhaps so are you too. And we try not to be, but it is part of our repertoire. So I'm going to talk a little bit about how science and pseudoscience can infiltrate our thinking and our processes in determining what works and what doesn't work. Think about it this way. Science and pseudoscience are not the same thing as good and bad treatment. That is, for any given treatment, we might think of these as being two orthogonal constructs in which the evidence base could be poor, that is, it clearly doesn't work, could be mixed, or the evidence base could be very good, meaning it very clearly does work. And at the same time, the way that people address the evidence around that treatment might be highly pseudoscientific, which we'll talk about. It may be highly scientific, or it might be somewhere in the middle. So if you imagine the entire universe of mental health treatments, be they psychotherapies, pharmacotherapies, other somatic treatments, and so on, every single treatment can be represented somewhere on this grid. And what you'll see is, yes, there are probably some good therapies, that is, they have a very good evidence base, and people have addressed them in a scientific way. And similarly, there are probably some really poor treatments out there, and people are addressing them in a pseudoscientific way, but there's also probably a lot of crossover. It is possible, therefore, for us to think pseudoscientifically about a perfectly fine treatment. And it is possible for us to think scientifically about a crummy treatment. Well, if we're trying to define these, and this is not a universally accepted definition of either science or pseudoscience, but I think Alan Cromer summed it up fairly well when he said that all non-scientific systems of thought accept intuition or personal insight as a valid source of ultimate knowledge. Science, on the other hand, is the rejection of this belief and its replacement with the idea that knowledge of the external world can only come from objective investigation. Essentially, he is making an argument for empiricism as the backbone of science. B.F. Skinner said it slightly more concisely, that science is a willingness to accept facts, even when they are opposed to wishes. Now, in understanding what science is, it's equally important for us to clarify what science is not. That I don't want to equate science with cynicism. It's easy, I think, to become nihilistic, to think nobody knows anything. The idea behind scientific thinking is that we're willing to entertain novel claims, and we also feel the obligation to subject those claims to intense scientific scrutiny. And I would also suggest that science does not, or should not, profess to have a monopoly on knowledge. Science is not the answer to everything. It does not hold all the answers. Now, I will suggest that right now it is the best way we have at arriving at those answers, but it does not necessarily mean that scientists know everything, or that the field of science has or ever will answer all of our questions. In fact, many, perhaps most, scientific findings will eventually be proven wrong. But that's a good thing if you're a scientist. Now, what then is pseudoscience? Well, pseudoscience is defined as a system of theories, assumptions, and methods that are erroneously regarded as scientific. Now, what I mean by that, then, is that pseudoscientific thinking applies a veneer of science to a logical system that is essentially non-scientific. Now, what I don't mean is that pseudoscience is the same thing as being wrong. The reason for that is that scientists are often wrong. In fact, they're usually wrong. Science is a behavior, it is an approach to evidence, and therefore it is not necessarily a statement that what one is saying is correct or incorrect. Scientists are wrong, and sometimes pseudoscientists are right, not necessarily for the right reason. And similarly, I also want to make the point that when we talk about pseudoscience, that I'm not referring to religion, and I'm not referring to metaphysics. That is, there are some areas of knowledge that make no claim to be science, and therefore they are not pseudoscience. There are some areas of knowledge and thinking and understanding that are clearly outside the area of science. They make no claim to be part of science, and that's perfectly fine. So that's not what we're talking about. Now, if we're trying to tell the difference between pseudoscience and science, we run into a problem of demarcation. And this has been pointed out several times, that there is no clear set of criteria that will always differentiate science and pseudoscience. When you get right down to it, the boundaries between these two concepts are fuzzy. Therefore, it's very difficult for us to come up with a very clear list of if you do this, it is science, and if you do that, it is pseudoscience. That having been said, others have made the argument that there's also no clear division between day and night. But that doesn't mean that they're the same thing. A reasonable person can tell the difference between when it is day and when it is night, even if he or she cannot necessarily understand exactly where the line is. So, how can we start to understand pseudoscience? What would we see that would tell us that perhaps we're looking at pseudoscientific thinking? One of the core criteria here is what's been called an overuse of ad hoc hypotheses that are designed to immunize claims from falsification. The idea is this, that when some new information or data comes to light that might challenge the basic premise of a treatment, the proponents of that treatment will start to come up with new hypotheses that essentially explain away what has been done. So, if somebody does a treatment study on a treatment that I love and it doesn't work, then I will come out and say, well, clearly they didn't apply the treatment correctly. That's an ad hoc hypothesis. We also see in pseudoscience an absence of self-correction. That is, when the model fails to develop as we get new information about a particular field, that's a sign that we're dealing with pseudoscience, that it's not connected with the scientific world. For example, one could point out that the field of astrology has not changed in over 1,000 years, despite the fact that our understanding of the cosmos has changed dramatically, as has our understanding of personality and human development. The fact that the field of astrology has not kept up with those changes in our knowledge suggests that we're not dealing with a scientific process of thought. We also see in pseudoscience a tendency to evade peer review. Peer review, of course, is not a perfect system, but it is one of the hallmarks of how scientists do their business. They subject their ideas to scrutiny of people who perhaps don't agree with them. Instead, when people are promoting pseudoscience, what they tend to do is rely more heavily on testimonials or anecdotal evidence. So this person got better this way, this person got better, this person got better, look how dramatically this person got better, without actually subjecting these to rigorous data analysis that would then be reviewed by one's peers. The emphasis in pseudoscience tends to be on confirmation rather than refutation. Many philosophers of science have said that scientists inherently are trying to disconfirm their theories. Now, that doesn't always play out, and remember, the lines of demarcation are fuzzy, and none of us, even those of us who think of ourselves as scientists, like to have our theories disconfirmed. It's not fun. But the process of science is designed to do just that. Instead, what we see is that pseudoscientific thinking is seeking out evidence specifically that affirms one's beliefs, clinging to that without paying attention to evidence or without generating evidence that might disconfirm it. The burden of proof is often reversed in pseudoscientific thinking. Typically, in scientific thinking, one would expect that if one has a claim to make, for example, this treatment is very good, then the burden of proof is on the person making the claim. That is, it is my job to prove to you that this treatment works. Instead, in pseudoscientific thinking, the logic goes a bit like, this treatment works really well, and since none of you can prove otherwise, I stand firm by my belief. There also is an absence of connectivity. That is, a failure to account for existing paradigms from other disciplines. There may be a treatment, for example, that proposes to cure a psychiatric disorder, anxiety, for example, post-traumatic stress, depression, by changing the flow of energy fields in the body, without necessarily paying attention to the science of human anatomy and physiology, which actually has no findings that would suggest that such energy fields exist or that they can be mastered in some of the ways that they say they can be mastered. Pseudoscience is also characterized often by what has been called obscurantist language. Language that is essentially designed to be confusing. Again, the boundaries are fuzzy, and scientists will use confusing language too. What we find, however, is that in pseudoscientific thinking, this language is used specifically to make something sound more scientifically rigorous than it really is. And finally, in pseudoscientific thinking, we see an absence of boundary conditions. That is, whenever one makes a claim, one would also make a statement about the conditions under which a particular treatment would or would not apply. But when we see a mental health treatment, for example, being marketed to cure not only anxiety disorders, but also depression and also marital problems, and also alcoholism, and also cancer, and it will improve world peace, you have to start thinking that perhaps we have an absence of boundary conditions here. Now, the American Psychological Association, the group with which I'm most familiar, has addressed this issue. In their code of ethics, they have stated, first, that psychologists' work is based upon established scientific and professional knowledge of the discipline. And when they talk about providing informed consent to the patients, they say, when obtaining informed consent for treatment in which generally recognized techniques and procedures have not been established, psychologists inform their clients or patients of the developing nature of the treatment, the potential risks involved, alternative treatments that may be available, and the voluntary nature of their participation. In short, then, the American Psychological Association has told its practitioners, you must make the use of the best science possible, and if you don't have good science to guide you, then you are obligated to tell the patient that we are now operating outside the boundaries of the knowledge that has been generated by science. What we are doing is experimental, and to provide the person with alternatives. Should you not want to go down this experimental path with me, here are the other things that you could do. That should solve the problem, right? After all, the American Psychological Association has spoken. And yet, we have a gap. What we have, and this is not simply in my country, but I think this is probably true worldwide, is that we have two fields of mental health that have developed. There is a group of scientists and perhaps scientist practitioners who believe one set of things, and then we have a group of other professionals, perhaps more practitioner-oriented, who believe another set of things. Increasingly, we find these two groups of people don't talk to each other very much. And when they do listen to what the others have to say, they tend to disparage it. So the scientists all tend to say, oh, those stupid practitioners, and the practitioners all say, oh, those stupid scientists. They both have a sense that neither really understands the perspective of the other or is particularly interested in the perspective of the other, and so they get angry at each other. Now, Carol Tavris, a social psychologist, took it a step further and said, calling it a gap is like saying there is an Israeli-Arab gap in the Middle East. It's a war involving deeply held beliefs, political passions, views of human nature and the nature of knowledge, and, as all wars ultimately involve, money, territory, and livelihoods. Ultimately, that's what this will come down to. So why would clinicians do this? I mean, the scientists wonder this all the time. We've done good research. We put a whole list of treatments out in front of people and said, here, use these, and the clinicians don't want to use them. Why would they do that? Well, there's several reasons. One, we can think of from a cognitive perspective, that we are all, scientists and practitioners, susceptible to cognitive biases. We make errors in our judgment. Confirmatory bias, for example, is all of our tendency to see what we already think, to pay more attention to things that confirm our belief. Yes, I said science tries to disconfirm, but that doesn't mean that scientists always do that. Scientists are prone to the same biases as everyone else. And we tend to favor those data and those pieces of evidence that confirm what we already suspect. We also have a tendency to be overconfident. We're all very educated, and that education sometimes carries risks. And there's a well-documented finding that one's confidence in the truth has very little to do with the accuracy of one's knowledge. In fact, there have been several studies that have suggested that the relationship may be inverse. The more confident you are that you're right, the more likely you are to be wrong. And I say this, by the way, knowing that this could easily be applied to myself as well. We have hindsight bias. We tend to pay attention to things that have already happened and interpret them in ways that confirm what we already know. So when, for example, a treatment fails, we tend to concoct hypotheses about why that occurred, and those hypotheses tend to conform to our existing beliefs. And we're all subject to the availability heuristic. Things that stand out, things that are dramatic, tend to hold priority in our thinking. So I may treat many, many patients over the course of a year, and the treatment is often quite boring. I do the treatment, they get better, or sometimes they don't, and then they go away. But perhaps I had one patient who got really, really better in a very dramatic way. And I can't quite explain it, but the person was wonderfully better. They're very, very sick, and now they're completely healthy, and they're jumping up and down, and they're happy, and they're calling everybody and saying how great Dr. Tolan is. And I'm trying to think about why that happened. What's going to end up happening is that later on, when I'm trying to make decisions about what to do with my patients, I'm going to start thinking back on my experiences, and that patient will come up first and foremost in my memory, despite the fact that he was the anomaly. He did not represent the average. He was the exception. And yet, because of the fallibility of human cognition, he's the one I start thinking about. And I might base my judgments on him. We also find, too, as clinicians, and I say this as somebody who treats patients as well as conducts research, that it's very difficult to get good feedback from our patients about what's working and not working, not the least of which is that we tend not to have any more contact with our patients after they terminate treatment with us. So the way that a treatment tends to end, if we think we're doing everything right, is the patient says, okay, doctor, I'm all better, and we shake hands and they go away, and I probably never see them again. Now, for all I know, 2 days later, the person had a depressive relapse, and they felt awful, and they weren't any better. But I don't know that, because clinical practice is not typically designed to allow us to collect longitudinal feedback. We also find, too, as we're talking with patients, that we're susceptible to the Barnum effect. P.T. Barnum, who said that a great circus has a little something for everybody. Well, a good psychotherapy probably has a little something for everybody. We do all kinds of things, and for all of us, there are probably elements of this therapy and this technique and that technique. And the fact of the matter is, it's very difficult for us to know at any given time which of those things is truly effective. But what we will tend to do is seize upon those things that seem to fit our thinking. And our clients have a tendency to agree with us. I mean, some of them don't, we call them borderline. But most of them, have a tendency to want to please us at least somewhat. And so if I start asking questions like, well, did that technique really help? And they may say, yes, doctor, it really did. Okay, well, why would the consumers accept this? I mean, after all, this is a consumer-driven process, is it not? I mean, why don't the consumers simply stand up and say, no, you will give me scientifically effective treatment? Well, part of it is that the general public is not great in scientific literacy. Now, I would say that's probably extra true in my country, but I think this is also true worldwide, is that the average person does not typically think in terms of science. We also see that in many ways pseudoscientific explanations are more alluring than science is. Carl Sagan speaks about this very eloquently in his book, The Demon-Haunted World. In many cases, pseudoscientific explanations are easier to get your head around. Well, you try talking with a scientist, and everything is about probabilities, and the scientist never will really confirm that he knows anything, and he always says, well, we think this, and we hypothesize this, and there's the theory. And, it can be maddening to talk to scientists, and I think I'm one of them. But if you talk to somebody who's promoting pseudoscience, they tend to come across much more simply. Yes, I have an explanation that will tie it all up very neatly for you, and I don't have to speak probabilistically. Therefore, I can make stronger claims. We don't have to be quite so tentative. It's also seductive when you think about some of the claims that are being made. I mean, in some ways, it would be really interesting and really wonderful if the stars controlled our destiny. And if we could then determine our destiny if we just knew enough about those stars. Wouldn't that be something? Wouldn't it be something if I could put some headphones on, listen to something while I sleep, and wake up feeling better? That would be great. I was working out today in the gym, and so you have to imagine I'm on the treadmill and I'm sweating and I'm very tired and I feel awful. And there's a TV up, and there's somebody on the TV who's selling a product where he has some massager thing. Have you seen this? And he's rubbing it on his belly like this, and it's supposed to make all of his fat go away. And sure enough, as a good testimonial, they had a picture of him at the beginning, and a picture of him at the end, and he looked great. And I'm sitting here running and sweating, and I've been doing this for a long time. And I find myself thinking just how seductive this all is. Wouldn't it be wonderful if that was really true? Wouldn't it be great If the solution to weight loss just involved buying this thing and rubbing it on your stomach, that would be terrific. And it's true in mental health as well. Wouldn't it be great if I could overcome my depression this way? And wouldn't it be great if this would help me stop drinking or get along better with my spouse? Wouldn't it be great if this would help me stop hearing voices? Also, the pseudoscientific interventions tend to be cheaper. They're easier. They're more accessible. Psychotherapy is hard to do. It's hard to get into it much of the time. It takes a long time. It's often expensive. Often it's hard to find a good provider. Whereas many of the things that are purported to be out there, I can simply order online. Wouldn't that be great? And finally, much of the information that the general population receives comes from the popular media. Now, I don't want to knock popular media. I'm on the popular media. But at the same time, it is important to recognize that the average consumer is not reading journal articles. And what they're usually doing is watching television or reading a magazine or something. And those kinds of media need to provide soundbite information. So whenever people are watching, they have to be able to put something into a message that can be consumed in 10 seconds or less. And as a result, it's very easy for us to learn on television, for example, that there are certain megavitamins that will make you feel all better, or that electroencephalography is a cure for ADHD. Now, again, those claims could be true. They might not be true, but the approach is essentially not a scientific one. Which leads me to the topic of chicken hypnosis, which I'm sure is on everybody's mind. I'll give you a minute just to think about chicken hypnosis. Are you familiar with hypnotizing chickens? Is this a uniquely American sport? Well, let me tell you about chicken hypnosis. If you come to America, particularly the American South, there is an old tradition, this goes back 100 years or more, of hypnotizing chickens. The idea is this. You take a chicken and you do some things to it, and as you'll see, this is a kind of pre and post, the chicken becomes completely hypnotized. It's a very well replicated phenomenon, something that even school kids do on the farm. It turns out there are 3 ways that you can hypnotize a chicken. This, by the way, comes from the the Farmer's Almanac in the United States. There are three ways that you can hypnotize a chicken. They are referred to as the sternum stroke method, which you see this man doing here, in which we stroke up and down the chicken's sternum. There's the chalk line method, in which we take a piece of chalk and we draw a line starting at the beak and going out 10 to 15 feet. There's also the oscillating finger method, in which the farmer will wave his fingers back and forth in front of the eyes of the chicken in a way of hypnotizing him. Now, in each of these cases, you get a similar result. The chicken becomes hypnotized. But of course, there is this question of, are there really 3 different ways to hypnotize a chicken? Well, it turns out that there is something that all 3 of these hip treatments have in common. We pay lots of attention to this man's left hand. What we're not really paying attention to is his right hand. What is his right hand doing? He's immobilizing the chicken, right? He's holding it down. There's a well-known animal phenomenon called tonic immobility. Happens in humans too. If you hold somebody or something down and immobilize it for a period of time, it will stop moving. It's evolutionarily adaptive. It's playing dead. The idea then is that if you want to hypnotize a chicken, really all you need to do is hold it down. You don't need to do all of these different things. Those things are superfluous. And yet, you ask any farmer, how did you hypnotize the chicken? He never talks about this. He wants to talk about these. In fact, they even get into fights, arguments, about which one is better. well, clearly the chalk line method is superior to the sternum stroke, when in fact, they're all because of holding the chicken down. We call that an incidental feature of the treatment. It's something that is not claimed to be the effective mechanism, and yet it probably is. The analog to this, when we start talking about humans and our work, is that the treatments that we have can work for reasons other than why we think. The fact of the matter is, in many cases, we don't know why a given treatment works, so we come up with hypotheses. And sometimes those hypotheses are right, and sometimes those hypotheses are wrong. Now, I'm going to teach you how to sell a pseudoscience. So in case you want to do this, and you want to make a lot of money in selling pseudoscience, here's the best way to do it. And by the way, it's been demonstrated that these strategies will work not only on consumers, but they will work on practitioners as well. So you pay attention to this, because we're all going to make lots and lots of money. I'll tell you about these different steps. They are, and Tony Pratkanis, who is a social psychologist, has documented these. I'll talk about each of these, but the steps here are to create a phantom, set a rationalization trap, manufacture source credibility and sincerity, establish what's called a grand falloon, use self-generated persuasion, construct vivid appeals, use pre-persuasion, make frequent use of heuristics and commonplaces, and attack one's opponents through innuendo and character assassination. Now, let me talk to you about how to do each of these so we know how to do it. The first is create a phantom. Creating a phantom means that we set out to promise an unavailable goal that looks real and possible, that would be highly desirable if that were possible. So, my phantom in the gym today was this idea that I could lose all of my belly fat by rubbing this thing on myself. And in 15 minutes, it said 15 minutes, in 15 minutes, I would look like Brad Pitt or something like that. That's my phantom. In this person's phantom, it's a cure for autism. It's an unavailable goal, at least one that's not available right now, that would be really wonderful if it were available. Set a rationalization trap. Setting a rationalization trap means encouraging the person to make immediate, small commitments to the cause. So, before I even try to sell you on something pseudoscientific, let me first ask you to take this free personality test. Now, what does that do? What it does is it gets you to already start saying yes to me, to start making small investments of your time. Before I will train you in this procedure, I want you to sign something that agrees that this is really dangerous in the wrong hands and that you won't show it to anybody. Well, that's setting a rationalization trap. It's asking people, before you've even started the persuasion process, to begin to make a commitment to you. And we know through social psychology that when you get somebody started making small commitments to you, they're far more likely to make a big commitment to you later. And they're far more likely to believe what you have to say. Manufacture source credibility and sincerity. Now, if you're going to do this, you must have a white-haired doctor to sell your products. It doesn't work unless you have preferably they have a beard and they wear a nice suit. The idea is, and now different strategies and different kinds of authority figures might appeal to different people, but the idea is that you have to put somebody up front that the people and the practitioners will believe in. Again, whether or not it's true, often it comes down to how much do I trust this guy? Does he look like he knows what he's talking about? We have to establish a grand falloon. This is a term from Kurt Vonnegut. Kurt Vonnegut described a grand falloon as a proud association of a proud and meaningless association of human beings. In order to really sell a pseudoscience, it's best if I make you part of a club. Because being part of a club makes you feel that much more allegiance to what I have to sell you. So how do you create a club? How do you create a grand falloon? Well, you put together people who share certain rituals and symbols, who might use the same jargon and beliefs. We start speaking a language that is different from others. We share goals and feelings. We share specialized information, perhaps information that only we can have. And importantly, have to have enemies. If you really want to get people to bond together, you have to have a shared enemy. Somebody has to be the bad guy. Use self-generated persuasion. This one is also right out of social psychology. Encourage your targets to persuade themselves by convincing others. Well known that if you are asked to convince somebody else of a fact, you yourself begin believing that fact that much more. So easy. As I'm putting you through the persuasion process, one of the things that I should ask you to do is to recruit others to the cause. So this is, for example, some herbal supplements, which again, let me say, might work, might not work, but right up front it's asking you, how can you help others? We can help your friends. You can have a real business opportunity. What kind of business is right for your lifestyle? But essentially what that is doing is bringing you more and more into the cause. It's turning you into a true believer. It's lowering your level of skepticism. We're going to construct vivid appeals. In order to construct vivid appeals, remember that availability heuristic, right? Data are boring. Statistics are boring. Nobody listens to that. What we listen to is a single case who got really, really, really better. Now, this is tough to read, but this is somebody who attended a seminar, and I went to this seminar to help myself, but then it helped me so unbelievably. I use it on a daily basis, and then I thought about my 7-year-old daughter, and I decided I would try it on her, so I began working on her energy meridians, and all of a sudden her problems got better too, and she went back to school, and now she's a happy little girl. And it becomes much easier for us to remember that man and his daughter and the testimonial than it is for us to think about the data that describes the outcome of that treatment. That's human nature. We use pre-persuasion. You have to define the situation so that you can win without much argument. Here's an example. This is tough to read, but it says, these are award-winning subliminal CDs for quick change. Sounds legit. But it asks, regular subliminal CDs are fine for regular people, but can mass-produced CDs from your local bookstore really improve your life? Can you trust the messages? Do you know how the CD has been made? Was the CD created by a reputable DVD inspirational company? Essentially what this does is it begins the discussion by setting the topic outside of the efficacy of the intervention. By distracting us away from the basic question of, would subliminal CDs help me? It instead asks us to think about this subliminal CD company versus that subliminal CD company. Now all of a sudden I'm thinking about, yeah, those bookstores don't know me with their mass-produced CDs, and all of a sudden I'm becoming less skeptical and more willing to buy what these guys are selling. That now all of a sudden the idea of a tailored CD by people who really understand me, that sounds wonderful. But it takes us off of the basic point. Again, I'm making no statement here about whether subliminal CDs are or are not effective. I'll let the data do the talking on that. I'm simply pointing out that we can address this from a scientific perspective, or we can address it from a pseudoscientific perspective. We have to make frequent use of heuristics and commonplaces. The heuristics come from Tversky and Kahneman and other behavioral economic thinkers. We know, for example, that when you say something is scarce, it's rare, that it becomes more desirable. Not everybody can do this. There's only a special group that can do this kind of treatment. The bandwagon heuristic. If I point out how many practitioners have signed up for this, how many of these I've sold, that makes you start to think that perhaps everybody knows something that I don't know. The representative heuristic. That is, if I give you case examples that will ring true in your head, whether or not they're really supported by mass data, you tend to believe it more. The natural and the goddess within commonplaces. We have a tendency to believe that things that are natural are good. We have a tendency to believe that things that are spiritual are good. It's actually harder for us to be skeptical. Maybe we've all seen this, and maybe we've all had patients who do this, who say, oh, I don't trust those antidepressant medications. Who knows what they're going to do to me in 20 years? And then they march right on down to the health food store and load up on minerals and herbal supplements that have never been tested at all. People are simply less skeptical when something is pitched as being natural. And the same thing is true of being spiritual. It's tempting to think that there is a spirituality, a goddess within, that is being overlooked by science, and that only this treatment can help us tap into. And then there's the science commonplace. Now, science gets used very interestingly in pseudoscientific thinking and in pseudoscientific sales. Pseudoscience has an interesting relationship to science. It has to sort of have two relationships. One is that it has to glorify science to a certain extent. That is, it has to be able to say, millions of people have done this and we've got this evidence, and you have to be able to put things out. So you have to be able to create at least the veneer of science, and in order to create the veneer of science, you need to be able to say that what I'm purporting to be is a good thing. And at the same time, you also have to disparage science in order to sell pseudoscience. So I'm going to give you a veneer of science which I'm going to purport is a good thing. And yet at the same time, my backup message is that also you should know that science doesn't have all the answers, but I do. So in this case, for example, this is, in the scientific cosmology, whatever doesn't exist obviously can't be real, but the energy psychology cosmology deals with a greater reality, a more inclusive reality. There are innumerable forms of general human experience which are not explainable by the limited cosmology of psychology, but which have perfect cause and effect in the greater cosmology of energy psychology. And you get a sense that there's a back and forth going on here with the relationship to science. It's simultaneously saying, yes, science is wonderful, and we are science, but also science is highly, highly flawed, and we're better than that. So it's an interesting dichotomy that has to be done when you're selling a pseudoscience. And you also have to attack your opponents. This one is critical. Right? Remember, you can't be part of the club unless there is a shared enemy. So how do you attack your opponents? People that perhaps are skeptical about the treatment that you like, or say things about a treatment that you think is really effective. Say things that like it's not effective or that it's no good. Well, Cicero said it best. If you don't have a good defense, attack the plaintiff. Discover an incredible new learning tool the government doesn't want you to know about. Well, who wouldn't be persuaded by that? Do you really want to go along with the government who doesn't want you to know the truth? No. I want to go along with the people who know the truth. Now, when you use innuendo like this, what does it do? Well, certainly it creates some in-group, out-group thinking. Right? By demonizing the person who is skeptical or critical, it makes it that much easier for others to start to buy what you have to sell. It also changes the topic of the conversation, right? I mean, if I come out and say, I don't know, I'm going to try not to pick on any particular one, but let's say I say a vitamin. So you really like vitamin E, and you think vitamin E will cure everything. And I come out and say, I don't think vitamin E, cures everything at all. And you say, well, obviously you have a hidden agenda and you're a very unethical person. You're probably getting money from the competitors who also don't like vitamin E. You're probably being paid by, the drug companies and so on. Now, you see what's happened now is that we've shifted the argument. Now, all of a sudden, we're not talking about whether vitamin E is particularly good or bad. Now we're talking about whether or not I'm an ethical person, and which is a fair thing to discuss. But notice how we have shifted the discussion. We also know, too, that using innuendo in attack has a silencing effect. Nobody likes being attacked, me included. And there is a tendency when you attack somebody for them to shut up. And so when you attack your opponents vigorously, there is a tendency for them to stop being so skeptical, or at least stop being so public with their skepticism. They don't want to go through that again. They start to ask, is that really worth it? Do I want that kind of headache? What's the harm? I mean, is this harmless folly, or is this really something to worry about? I would suggest it's something to worry about on three different fronts. I think that there's reason to believe that there is direct harm to patients. I'll talk about these a little bit. But we know that there are treatments that harm people. Never mind the treatments that simply don't work. There are treatments that have been demonstrated to do harm to people. And yet, they continue to be practiced. Why? Because they're being sold. We also know there's always hysterical epidemics that sweep through the population. Hysterical mental health epidemics. Why? No, because we have a tendency to buy into theories that perhaps are not really solid. And myths persist. The general public doesn't know a whole lot about real psychology. They don't know a whole lot about real psychiatry. They have a tendency to believe certain common sense heuristics that they think are related to what we do. And these things persist essentially because of a lack of scientific skepticism. We also know that treatments that are the result of pseudoscience cost people money, and they cost time. And one of the things that we see in economics, they refer to it as opportunity cost, but it's a very real phenomenon, is that when somebody partakes in one particular kind of treatment, they are less likely to partake in any other kind of treatment. That's been demonstrated in epidemiologic research. When people use, for example, herbal supplements, they are less likely to take medications that have been approved for use for that disorder. People don't just simply add on to their existing treatment. They really do choose this over that. And I would suggest that the persistence of pseudoscientific thinking is inherently bad for the profession in terms of litigation from patients that have been harmed, in terms of our ability to collect payment for the services that we provide, and in the erosion of the scientific foundations of our work. Now let me talk about the harm to patients. Now, this is not necessarily a statement about pseudoscience. Remember, the evidence base for a treatment and the way it is promoted are two potentially different things. But what I will say is that pseudoscientific thinking is probably one of the mechanisms by which some of these treatments persist. We know through randomized controlled trials, for example, that a treatment called critical incident stress debriefing, an intervention that was designed to prevent the onset of PTSD following a mass trauma, can actually cause PTSD or make PTSD symptoms worsen. And the average person who receives critical incident stress debriefing is worse off than the average person who did not receive it. The Scared Straight programs, they take delinquent children and take them to prison so they can be frightened by all the scary prisoners with their big tattoos and their goatees and their piercings and I don't know what else. It turns out that doesn't actually turn them away from crime. It actually increases crime among those youths because the prisoners look cool. Facilitated communication. This is a really interesting one. This was designed as an intervention for autism. The theory behind facilitated communication, which I would add is disconnected from what's known about the pathology and the pathophysiology of autism, is that autism is primarily a language problem, that the person is completely cognitively intact. However, they are unable to express themselves because they essentially have a language and motor problem. So they came up with the idea that we get a keyboard, and you can see here's a person with a keyboard, and a facilitator. And the facilitator will hold the patient's wrist like this and help them to control their spastic movements and press down on the key of a keyboard so that they can type things out. Now, one of the things that happened when facilitated communication became popular is there was a rash of accusations of sexual abuse. It turned out large numbers of these autistic children reported that they had been molested by people who were entrusted with their care, their parents, their daycare teachers, their doctors. Many people were prosecuted. At the end of it, it took an elementary school girl to conduct the first randomized controlled trial of facilitated communication, and she did it very simply. She had the person with autism and the facilitator sitting here, and she had a split screen in front of them. And she simply said, I want you to type what it is that you see on the picture that I'm going to show you. And she would show the autistic child one picture, a spoon, and she would show the facilitator another picture, a cat. And every single time, the message was C-A-T. These messages were not coming from the autistic child, they were coming from the facilitator, perhaps unconsciously. An interesting phenomenon in and of itself. But it speaks to the issue of how much damage can be done when we do things that really haven't been proven to work. Attachment therapy, another very dangerous one. Here's a picture of a child, also autistic, being held down by his mother. The idea is that if you hold them down long enough, they will accept their love. They certainly stop thrashing. So do the chickens. And in fact, there was a very well-publicized case in Colorado in the United States where they did a variation of this, where they rolled a child up in a carpet, and then adults, piled on top of her to simulate being in the birth canal, with the idea that she would claw her way out of the birth canal and re-enter the world and love her parents again. And of course, she died. And harm is being done. And yet, I would also point out, these treatments are still being conducted. They're being conducted in the United States. They're being conducted in Sweden. The recovered memory techniques, also leading to kind of a rash of sexual abuse allegations. This idea, for example, that if I hypnotize you, we will find repressed memories of bad things that have happened to you in childhood. The DARE program, that's another really popular one, and it remains very, very popular in the United States. They come out and they do psychoeducation to high school children, telling them not to drink and not to use drugs. Seems great. Everybody loves it. The government pours a lot of money into it. When they've conducted randomized controlled trials, guess what? It makes alcohol and drug use go up, not down. That the kids who are going to drink, they're going to drink anyway. And the kids who are kind of on the fence listen to all that and go, hey, that sounds pretty cool. I talked about the hysterical epidemics. Maybe you remember some of these. There have been these ritual sexual abuse epidemics. Remember, there was a time when it just seemed like every daycare was a satanic cult that was engaging in ritual sexual abuse of children, and many people bought that hook, line, and sinker. There was a wave of multiple personality disorder that came through. It was huge. There was a point, I think it was in the 80s, when it just seemed like every patient had multiple personality. Then it sort of stopped being cool, and now nobody has multiple personality disorder. There was a point when everybody had alien abduction. Well, okay, not everybody, but more than you would necessarily expect. John Mack, a very prominent Harvard psychiatrist, was largely responsible for that epidemic, suggesting that lots of mental disorders were essentially the result of implanted thoughts and memories by aliens. And then we also know there's this persistence of myths. This is what the public generally thinks. Now, you might ask yourself, true or false? I'll give you a hint. The answer to all of these is false. But the average person, when you ask them about the fields of psychology and psychiatry, when you ask them about mental health, they will endorse these. Most abused children will become abusive parents. Most children of alcoholics will become alcoholics. Childhood trauma will invariably produce emotional symptoms that carry on into adulthood. Most traumatic experiences are repressed. And when they're repressed, hypnosis can reliably uncover them. And if you're angry and you don't express it, the anger will build up like steam in a teapot, resulting in an explosion. None of these have any basis in fact. And yet, the myths persist. Why? Because we lack the scientific skepticism. We haven't disseminated the truth to the consumers. So, if we're a practitioner, and something is presented to us, here, go to this workshop, try this treatment, read this book. There are some questions we could ask ourselves. Is this testable? This relates to the issue of falsifiability. Is this treatment testable, or is it unable to be tested or disproved? Can we at least hypothetically think of a research finding or a series of research findings that would tell us that this is not true? Turns out there are a lot of ideas out there that are simply not testable. There's no way we could ever disprove them. Is it unchanged? Does that treatment remain unchanged even in the face of contradictory evidence? As, for example, part of a treatment starts to become superfluous when it comes to the evidence, as we start realizing that this part of the treatment seems to be helping and this part of the treatment doesn't seem to be helping, do the proponents of that treatment then drop this that doesn't help? Or do they cling to it? Do they give it an ad hoc hypothesis to explain that away? Is the rationale for the treatment based only on confirming evidence, with disconfirming evidence being either ignored or minimized? Is the evidence being presented to me anecdotal? Does the evidence in support rely primarily on personal experience and anecdotal accounts? There's one treatment that's being sold very aggressively, and it is quite popular, in the United States at least, in which the main evidence was the results that were obtained on a daytime television talk show, where this psychologist went on, did his treatment, the patients recruited from the audience felt better, and that goes on the website. This is the evidence that this treatment works. Are the claims of the treatment incommensurate with the level of evidence needed to support those claims? There's an often repeated quote that says, extraordinary claims require extraordinary evidence. If you're going to claim to treat anxiety and depression and alcoholism and marital discomfort and cancer and war, you should be prepared to provide some rather strong evidence for those claims. Have they avoided peer review? Are the treatment claims unsupported by evidence that has undergone truly critical scrutiny? For example, there are a number of vanity journals that are out there that look scientific, and yet they're being put out there solely by the people who benefit from this treatment being promoted, who have a financial stake in it. It's as if Pfizer created the Journal of Zoloft, the Journal of Sertraline, and that everybody who wanted to publish on sertraline would publish there. It's not exactly the same as a good peer review. Is the treatment disconnected from well-established scientific models or paradigms? Think about alien abuse just as an example, right? They're alien abduction. Now, if anyone here has been abducted by aliens, I don't want to offend you, so you don't have to listen to this part. But when you think about it, the notion that mental illness is caused by aliens and alien abduction, for us to buy that notion, would require us to rewrite the laws of physics, time, and space, would it not? That's a pretty clear disconnect from what the rest of science has to say about the topic. Is the treatment being described by fancy new terms that appear to be scientific, but on further examination are not scientific at all? There are treatments, for example, that talk about meridians, neural networks, other things that have kind of a sciencey sound to it, but don't have any basis in actual scientific fact. Is the treatment approach based on claims that are grandiose or on outcomes that are poorly specified? And is this treatment claimed to make sense only within a vaguely described holistic framework? This is one that you see a lot, and you see it a lot when people are talking specifically about certain assessment methods. As the data come in saying, look, this assessment method doesn't really tell you very much, the counter-argument is usually, well, you would never just use that. We use a holistic approach in which we take all of the evidence into consideration in order to diagnose our patient. Yes, well, that's fine, but that does sort of avoid the basic issue, that the thing that you're purporting to do doesn't seem to work, right? That essentially the argument of holism is just another ad hoc hypothesis. So what can the field do about this? The field of psychology, the field of psychiatry, the field of social work, the field of mental health therapy. We need to do a better job of emphasizing critical thinking skills in graduate training. Now, depending on where you are, sometimes you get all of your clinical and research training in the same place within the same degree. And in other places, you get your clinical training first, and then you go back for a research degree. I would argue that we need to emphasize critical thinking at all points along this spectrum. That the critical thinking should not simply be reserved for the research programs. In my country, we have two different kinds of doctorate in psychology. We have the PhD and the PsyD, with the idea being that one had a more research flavor and one had a more practice flavor, and that's fine. But we need to emphasize critical thinking skills not only for those people that are going into research, but also those people who are going into practice, those people who will be sitting in front of the patient. We need to do a better job of disseminating information about our scientific findings and the process of science to the public. The public has very little understanding of what works in mental health treatment, and they have very little understanding of what doesn't work in mental health treatment. There's no real body that's out there talking to the public in as vital and imminent a way as, say, Dr. Phil He reaches a lot more ears than the American Psychological Association ever has. We need to ensure that the continuing education that we provide to our clinicians and to our researchers is grounded in adequate scientific evidence. This is an ongoing fight, by the way, in the United States, in which if you are a psychiatrist or you're a psychologist, you can go and get continuing education credits, which is required to maintain your license, in all kinds of things. All kinds of things that lack scientific evidence. You can go to a shaman sweat lodge. You can do Jungian sand tray therapy. You can do, look at the clouds. I don't know, tea leaves. I don't know what you can do. The idea is that you can get credits for doing those that have nothing to do with the scientific processes of our profession. This one may be a bit more controversial, that the field and the governing bodies of the field need to impose sanctions on practitioners who routinely use techniques that are devoid of scientific support. In my country, and I think yours as well, there is no requirement that practitioners use scientifically validated strategies. I mean, there's that APA code of ethics, but you don't necessarily lose a license for that. It's a guiding principle. Right? The field needs to do a better job of identifying when somebody has stepped out of bounds. We need to focus less on trademarked therapies and more on the empirically supported principles of change. Now, here's where I will give a bit of my own bias away. I'm not a big fan of any treatment that has a name, especially if the name is in all capital letters, because I suspect that that's a package that's being sold. And by the way, I will put cognitive behavioral therapy on that list, because I think that those names mostly obscure what we're doing. There are over 400 different kinds of mental health therapy, just psychological therapy, let alone the medications. And I doubt highly that there are 400 different mechanisms by which patients get better. That just seems a little too complex even for the human brain. We need to be paying more attention then to disseminating information to ourselves and to the public about what specific processes work in helping people recover from mental health problems, not necessarily in which package with a little trademark or a patent sign after it helps. That obscures rather than enlightens. And we need to raise the bar for what is considered empirically supported. Now, when I talk about that, this is the empirically supported therapy movement, which speaks directly to the dodo bird verdict that we were speaking about before. There's an increasing movement toward asking people to adopt treatments that are empirically supported, meaning supported by evidence. And the organization to which I was recently elected president, the Society of Clinical Psychology, has been the driving force in identifying what the empirically supported psychological treatments are, and I believe we got it wrong. And here's why we got it wrong. Right now, the Society of Clinical Psychology has two criteria, two categories of efficacy that they will assign to a particular treatment. Cognitive therapy for depression, exposure therapy for PTSD, you name it. A treatment is determined to be possibly efficacious if it has been proven to be more effective than no treatment in a single randomized controlled trial. And it is considered efficacious, that is, they get to drop the possibly, if it's been shown to be more effective than no treatment in 2 randomized controlled trials. Problems with this are, 1, nowhere in here does it make any statement about the effective mechanisms of the treatment. You don't have to understand why your treatment works. You simply have to demonstrate that it works better than no treatment. And there's no provision for negative findings. Remember, if I have 2 positive randomized controlled trials, I'm in. I have an effective treatment. Anybody who has studied statistics knows that if your p-level is set to 0.05 and you study something 100 times, you will probably have 5 false findings. I'm in. There is no way, for example, of getting off of the list because of my 95 negative findings. In fact, I can even have other findings that show that my patients got worse, that they were harmed. And yet, I would still have an empirically supported treatment. I would also add, too, not on the slide, that there's no provision here for how any given treatment fares against another treatment, or even against a well-validated control condition. Compare this, by the way, to how drugs are approved. For a drug to be approved, it has to go through animal testing, preclinical testing, clinical testing, replication of the clinical testing on a large scale, safety testing. By the way, when it's being tested, it's tested not against no treatment. It's being tested against a placebo in a double-blind trial in which the patient hopefully doesn't know whether they're receiving the placebo or not. Sometimes it's even tested against an existing therapy. There's no specification that we do so when it comes to psychological therapies. The bar is too low. Theoretically, then, anything I come up with, if I come up with shoe-bashing therapy, in which I'm going to cure your depression by bashing you over the head with my shoe, my guess is that if I chose to conduct a randomized controlled trial of it and compared it to nothing, you'd probably find a difference. Maybe you're so depressed, you're just happy to have me hitting you on the head with the shoe. So you feel somewhat better, and I'm on the list. I'll tell you who talked about this in a really eloquent way were Jerry Rosen and Jerry Davison, who came up with the concept of purple hat therapy, one of my favorite developments in the field of clinical psychology. Here's what they say about purple hat therapy. Hypothetically, a doctor could ask clients with driving phobias to wear a large purple hat while applying relaxation and cognitive coping skills to in vivo practice. The practitioner places a band of magnets in the purple hats, claiming that particular algorithms for positioning the magnets are determined by age, sex, and personality structure of the client. When properly placed, so the practitioner claims, the magnets reorient energy fields, accelerate information processing, improve interhemispheric coherence, and eliminate phobic avoidance. The inventor might call this method purple hat therapy, conduct a single randomized controlled trial against no treatment, and apply for listing as an empirically supported treatment. And I'm going to leave you then with a final quote from the physicist James Oberg, who, in looking at all of this information about scientific thinking and pseudoscientific thinking and how we should think straight about the treatments that we're applying, said, "Keeping an open mind is a virtue, but not so open that your brains fall out."